Hello, friends. So I'll be talking on this journal review, a very interesting journal article that came in Lancet in March 2023. So it's on a nutrition trial. So before that, we'll just look into what is the background that we are aware with, in the area of nutrition. So when you look at the standard nutritional goals today, so if you look at the Indian guidelines or if you look at the ISPEN guidelines or ASPEN guidelines, so the suggested sort of a protein requirement is around 1.2 to 2 grams per kg per day, and that gets 1A recommendation, which is strong recommendation with a reasonable good level of evidence. And if you look at the calorie intake, so the calorie that is suggested or recommended is 25 to 30 kilocalories per kg per day. And in severe hypercatabolic, the calorie to nitrogen ratio, there is a lot of increase to 120 is to 1. And in burns, you have to use a specialized formula like Toronto formula to calculate the calorie need. So this is the sort of understanding that we have on the standard recommendation that protein is 1 to 2 grams and calories 25 to 30 kilocalories. So this has been historically been challenged and multiple trials, maybe close to 20 to 30 trials, good trials are there, where they have looked at whether this protein is good enough or one should give very high protein, or in the early phase of illness, should we give less protein, so on and so forth. And so is the case with calorie. So the recent trial that came was the target trial, which looked at whether low calorie and high calorie, keeping the protein same, whether it made a difference. So there are multiple trials. So this has been a sort of an area of debate to determine what is the right protein and right calories that we should give. In the light of this, we got this new trial, which is NUTRIREA trial. So, and when we talk about protein intake, the whole intent that we give protein in a critically unwell is to maintain the protein, whole body protein balance. And this whole body protein balance is needed to maintain the muscle mass and to retain the muscle strength. And that is because most of the listeners here would subscribe that in critically ill patient, when someone is unwell, there's a lot of wasting that happens. There's a lot of loss of muscle that happens, and we need to enhance the protein intake to preserve the muscle mass, and this has shown to have a bearing on the recovery process. But the studies again are sort of diabolical and not very certain whether by supplementing excess protein, whether it improves survival, improves recovery. It is still an area of debate. So we do not know for sure how much high proteins we should be giving, when we should be giving. Now there's a new concept of just giving high protein is not good enough during recovery phase. It needs to be complemented with exercise to improve the outcomes, so on and so forth. So this has been an area of debate, and multiple studies have been coming out, and multiple guidelines from Europe, US, and Indian guidelines have been coming out. But our general understanding is okay, 1 to 2 grams per kg per day is acceptable. Even if you look at Indian guidelines, even if you look at Aspen guidelines, which comes from US, this is the sort of accepted norm that we subscribe to, giving protein of 1.2 to 2 grams per kg and calories of 25 to 30 kilocalories. But in hypercatabolic patients, patients with trauma or in burns, it is desirable that we give much higher protein to the tune of 2 to 2.5 grams per kg per day. This has been our sort of current understanding. And there are even debates in critically ill patients, although we say that initial protein intake that they need is 1.3 grams per kg per day. So this Canadian paper has shown, although we may be giving 1.3, but the actual goals attained is only around 55% of the protein that is given because of various reasons, because the absorption may not be happening well, or protein distribution may not be happening well, or the targets that is intended to be achieved is not achieved. So many a times, although we say we are giving 1.3 grams, but the actual protein that is given to an individual is around 55%. So this is the sort of a backdrop on which this particular trial will come. So what today we understand is, okay, in the acute phase, if we divide the phases of critical ill, in acute phase, we call it as day 1 to 4. So it is agreed that we start very slow at 25% of the protein intake or 25% of the caloric goals that we have, slowly increase up to 75% by day 3. And from day 4, you can increase to the 100% of the target, which is 1.2 to 1.3 grams per kg per day of protein, is what we can look at achieving on day 4. And after that, post ICU, you can sort of crank it up to 1.5 to 2 grams of protein, 2 grams per kg per day of protein, and calories, you can go up to 30 kilocalories. At day 4, you can sort of try to attain 25 to 30 kilocalories. But post ICU discharge, you can look at 30 kilocalories, and proteins, you would crank it up to 1.5 to 2 grams per kg. And post hospital discharge, once they have recovered from acute illness, once they are improving to wellness, so you can increase the calories up to 35 kilocalories, and protein intake can be further cranked up to 2.2 to 2.5 grams of protein per kg. So this sort of a step ladder approach to cascading your calorie intake, cascading the protein intake seems to be desirable. But what I want all the audience to focus is this first sort of a pillar, where there is a mention that in the acute illness, it is okay that you can start at 25%. But should we increase to 75% at day 3? And should we increase to 100% at day 4 is the matter of contention, for which this particular trial came, NUTRIREA. So the whole backdrop of this trial is this: whether up to day 4 or day 7, whether should we attain 100% targets, or is it okay to keep it at 25%? I think that is the sort of a answer that we wish to make, and these authors have tried to make. So as you see, the title of this trial, this came in Lancet in March 2023, low versus standard calorie and protein feeding in ventilated adult patients with shock. So they took very sick patients. So the hypothesis is whether early restriction of calories and proteins versus the standard. Standard is where you give 1 to 2 grams per kg per day of protein and 25 to 30 kilocalories we give, whether it improves outcome, whether the restriction. So I showed you that step ladder approach in the early phase. Should we attain 100% of the targets by day 4 to day 5, or we just continue to restrict them to around 25%? Would that improve outcome? Is the hypothesis. So the methods is it's a multicentric randomized controlled trial. It's a very big trial done in France in 61 ICUs in France. So it was done between 5th July 2018 to 8 December 2020. So the inclusion criteria was they took all adults more than 18 years. So just pay attention, they took very sick patients. They took patients who were mechanically ventilated and who were needing vasopressors. So they did not take stable ICU patients. They took very sick ICU patients who were on ventilator and who were on vasopressors, and they randomized to low and standard groups. Low group, as I said, they gave only 6 kilocalories per kg per day. So as I said, the standard recommendation as per Aspen, Eastern, and Indian is 25 kilocalories at least, and 25 to 30. And then during the recovery phase or post ICU discharge 30, and after that you go up to 35 kilocalories. Here they give 6 kilocalories per kg per day. And protein, if you see, as I said, it is 1.2 to 2 grams per kg. Here they gave 0.2 to 0.4. So you can look at it as around 25%. If you look at the step ladder fashion, they have kept it at 25% for up to 7 days. So they gave 0.2 to 0.4 grams per kg. In standard, they gave 25 kilocalories per kg per day. And protein, if you see, they gave 1 to 1.3 grams per kg per day. And this was given for 7 days. So if you see that step ladder, where by day 4, the sort of recommendation is you achieve up to 100% of the target. Here, it's still 7 days, they kept low protein, 0.2 at 25%, and calories also they kept at 6 kilocalories. So the primary endpoint was to look at the time to readiness for ICU discharge, which is the time taken for discharging the patient from ICU. And they looked at 90-day all-cause mortality as the primary endpoint. Secondary endpoint, they looked at risk of infections, GI events, and liver dysfunctions. They looked at as secondary events. So when you look at, so it's quite a provocative study. So when you look at the results, as you see, it was a very big sort of a study, 3,044 patients. The low group, there were 1,521 patients, and in the standard group, there was 1,515 patients. When you look at 90-day mortality, as you see, there was no difference between the low group. So even though you restricted calories to 6 kilocalories per kg per day for 7 days, and proteins at 0.2 to zero point 0.4 grams per kg, the mortality was no different in the low group and standard. But look at this, which is very provocative. The time for readiness to ICU discharge means the patient got discharged much early on in the low group versus standard group. So patients where they were given underfeeding or trophic feeding, they got discharged much earlier at 8 days as opposed to standard, and that attained statistical significance. And when you look at secondary endpoints, again, it is very provocative. The secondary infections, there was no difference, although it sort of tends to attain, but it did not attain statistical between low group and standard. But when you look at the GI side effect, vomiting was less because obviously you're giving less calories, sort of trophic feeding. So the risk of vomiting was less in the low group. And when you look at the bowel ischemia, even bowel ischemia was less in the low group as compared to standard. So that is also very provocative that bowel ischemia, secondary endpoint, bowel ischemia was less. Even the liver dysfunction was less in the low group as compared to the standard. And this is very important for intensivists. The duration of mechanical ventilation was significantly less in the patients who were fed less, who were given less calories, less protein. The duration of mechanical ventilation was less, which is all very provocative and quite interesting to see how these results have manifested in this NUTRIREA study, which is going to change our whole thought and paradigm shift into the way we would look at nutrition in this sick patient. So this is just tables I'm showing you with regards to the comparison. So they were all nicely matched. As you see, there was no major difference between the baseline characteristics of the low group and standard group. And this is, as you see, this is a very bold sort of a provocative secondary endpoints. If you see vomiting was less in the low group and the need for prokinetic drug was less in the low group, constipation was sort of no different, but diarrhea was significantly less. So all the GI side effects were less in the patients who got less calories and less protein. And if you look, the glucose levels also was high in the standard group, was less in the low group, which is good. And the need for insulin also was more in the standard group, which is less in the group which was underfed. Obviously, you feed less, so sugars will be less, and the need for insulin will be less. And if you see the liver enzymes also was less in the low group as compared to the standard group. So overall, very sort of a provocative findings that all the secondary endpoints showed favorable benefit in patients who were fed less. This is interesting for intensivists. The need for prone ventilation was more in the standard group and less in the low group, which means the sick patients who are ventilated and who are on vasopressors, the need for proning was more in the standard group as compared to the low group. The authors in the discussion mentioned the probable reason is in patients who were getting more calories and more protein, the volume of fluid given, the volume of the feed was much higher. So that's why that contributed to worsening of ARDS. So there was increase in the cumulative sort of a fluid balance or more fluid was administered to attain that much of calories, and that led to patients with ARDS needing more prone positioning is what authors subscribe in the discussion. So it's a very bold study which really changes the way we would be looking at it, nutrition, because initially we were really overzealous in trying to attain the targets of 1 to 2 grams protein, and we always felt that we should give more protein and less calories is okay, is what we were thinking. But this study really changes the whole dimensions and basically gets us to ponder whether we can underfeed the patients. So what did the previous study show? So even the trends in the previous studies, which looked at low versus standard, there were four good studies which has compared the low calorie versus standard, and most of them showed trends towards lower mortality without attaining statistical significance. And these are the studies. So one study is from Australia, which is a target study by Chapman, with whom I worked in Royal Adelaide, and this is Arabi et al., Canadian and Saudi study. Rice and Merrick. All these four studies did show those signals or trends of lower mortality. We did not attain statistical significance. But what was sort of impetus for doing these studies was observational studies, which showed that calorie deficiency, if you give less calories, the observational studies showed increase in the risk of infection. But this was not shown in these randomized control trials. Although observational studies said underfeeding is bad, that it leads to increased infection, but the randomized controlled trials looking at the permissive and trophic feeding did not show increase in the risk of infection. And if you see in this particular study, in fact, the secondary endpoints were much better off in the underfed patients. So the target trial, which compared high calorie and low calorie, also showed no benefit by unnecessarily increasing the calorie intake of these patients. So this was another study, EPANIC trial from Belgium, which compared early parenteral nutrition versus late. Early parenteral nutrition is where they had a higher calories. Late parenteral nutrition is where calories was restricted initially. Even here, they showed the mortality was similar between early parenteral and late, because you have to look at it as late parenteral nutrition group having had got less calories in the initial phase. So that showed mortality, but late parenteral nutrition, which means which were calorie restricted in the early on, showed reduction in the infection and reduced need of RRT and reduced ICU length of stay and reduced duration of mechanical ventilation. So you can sort of relate EPENIC trial to this NUTRIREA trial, that you don't overfeed them in the first few days, first 7 days, like what they did in NUTRIREA. Even here, early parenteral is where they gave calories, where they attained the targets in the first 7 days. In the late parenteral, they sort of did not attain the goals in the first few days. Later on, they attained. So it showed favorable secondary endpoints. Although mortality was similar, it did show reduction in the risk of infection, reduce in the RRT, reduce in the ICU length of stay, and reduce in the duration of mechanical ventilation. So why do we think such a findings were shown in this NUTRIREA or EPANIC? So the authors do say the mechanism of clinical benefit is unclear, but there are certain hypothetical explanations given. So anorexia means where when we are very sick, so bad body sort of undergoes some sort of a catabolic phase where there is adaptive response with increase in the immune response, and there is sort of a which compensates for the metabolic disturbance, and there is reduction of metabolic disturbance. And some of the other hypothetical explanation is there is a autophagy that sets in when someone gets very sick. And this is a mechanism to maintain, it is said it is maintains the cellular integrity, especially in the muscles, and which helps in the recovery in the later phase. So this is what has been hypothesized, and this has been shown by a small molecular study or a physiological study done by the Swedish group. So basically, this is a sort of a physiological compensation that happens, which maintains the integrity of the muscle cells, which later on helps the muscles to recover much better, is what is postulated. And another thing is there is a gross sort of a oxygen supply and demand sort of a mismatch that tends to happen, which is compensated by sort of underfeeding or giving trophic feeds early on. And this mismatch is shown to contribute to all the liver dysfunction, because if you overfeed them in the early on, so there is a mismatch between the supply and demand, which leads to liver dysfunction. So this has been postulated as a reason for the liver dysfunction that sets in with overfeeding in the early phase. So the limitations of this study is there was no blinding, because some of the patients who were underfed and overfed, one could not blind. So there is possibly there may be an element of bias there. The strengths of the study is it was a pragmatic design study. It was a very large study involving 61 ICUs, multicentric. So that gives a lot of strength to this study. And the sort of enteral nutrition and parenteral nutrition goals that they attained were standard sort of goals that they attained with the standard formulation. So that was standardized. The enteral nutrition and parenteral that was given to attain the goals was standardized, and none of the patients were overfed, which could have infused certain fallacies in the study. So these were some of the strengths. So the conclusion of this very provocative study, NUTRIREA, is early restriction of calories and proteins as compared to standard, where you are only giving 6 kilocalories per kg per day and zero point 0.2 to zero point 0.4 grams of per kg of protein per day, vis-a-vis 1 to 1.2 grams per kg per day of protein for first 7 days, although did not show reduction in mortality, but led to faster recovery, because we saw the duration of ventilation was less, and it showed reduced complications. The reduced complications is all the GI disturbances, vomiting, diarrhea, bowel ischemia, all and liver dysfunction. All this was significantly less in the group which had a restrictive fluid. And certain secondary endpoints like duration of mechanical ventilation also was less in patients who were underfed, and the need for proning also was less in patients who were underfed. Although mortality wise there was no difference, but a lot of secondary endpoints had favorable benefit. The glucose control was better. The need for insulin was better. So all in all, the take home is maybe with this NUTRIREA trial and the EPANIC trial, both sort of concur with each other that we don't need to be possibly overzealous in first 7 days, especially in a sick mechanically ventilated patients to attain our big targets. So we can underwhelm ourselves and take it easy with regard to attaining those goals is what possibly we can subscribe. So it will be interesting to see the newer studies because nutrition is a big area. So because there was a lot of enthusiasm earlier on when we spoke about higher protein intake and lowering the calories as the way to go. But now with this trial, it really emphasizes that we really don't need to chase even the higher protein in the initial 7 days is what we can conclude. So thank you one and all. You can visit my website www.drpradiplamgar.com to read to this lecture. So thank you one and all.